s'arrête. Nous passons à la communication suivante. Est-ce qu'il est là? Barche. Ok. D'accord. Donc, cette communication va porter sur les facteurs prédictifs de mortalité dans l'insuffisance cardiaque en Afrique subsaharienne. Donc, dans le cadre du registre d'insuffisance cardiaque créé par le centre de Douala. Alors, Barche, docteur Barche, vous avez la parole et vous avez 7 minutes. Merci beaucoup.
Thank you very much, President, for giving us the floor to present this work. To present this work, which is focused on 36 months predictors of mortality in patients with heart failure in sub-Saharan Africa, the perspective of the Douala Heart Failure Registry. So, as we know, heart failure is a major public health challenge, and the etiologies are both infectious and non-infectious. And in sub-Saharan Africa, the mortality rate of heart failure is higher than other regions of the world. And also, we expect the prevalence of heart failure in Africa to increase due to the pooling of cardiovascular risk factors as we are in an epidemiological transition. So when we do some literature research, not much studies have been done to evaluate the long-term outcomes or the predictors of heart failure in sub-Saharan Africa, and the tissues heart failure remains the largest cohort which has evaluated predictors of heart failure outcomes in sub-Saharan Africa. So we therefore decided or had as objective to determine the 36 months predictors of heart failure mortality in patients who were recruited in the Douala Heart Failure Registry. And to attain these objectives, we conducted a prospective cohort follow-up of patients who were recruited in the Douala Heart Failure Registry. And the Douala Heart Failure Registry is an ongoing prospective data collection of patients in 4 different cardiology units in Douala. And here patients were followed up after every 6 months from index date of recruitment. And baseline information collected included demographic characteristics, echographic and measure or relevant clinical parameters. The study confirmed or was conducted in accordance to the declarations of Helsinki, and we used the cost proportional hazard models to obtain predictors of mortality. So actually the registry has a of 340, and after 36 months of follow-up, we had 29 cases of loss to follow-up, and we defined loss to follow-up in our study as patients' inability that were unable to reach after 9 consecutive phone calls in the space of 4 weeks. Thus, we had 218 patients that had a complete follow-up. So, in general, the mean age was 64 years. And the females were slightly older than the males. And based on whether the patient was an inpatient or an outpatient, we had a third of the patients were inpatient, that is patients who had the signs of decompensation during recruitment. Hypertension was the most represented associated disease. More than 60% of the population had it, hypertension. So after a follow-up of a median follow-up of 33 months, 150 participants died, and thus the mortality rate was 47%. Almost half of the cohort died. And following the ESC classification of heart failure, the most represented was a heart failure with restriction, and a third of the participants were heart failure with mildly reduced ejection fraction. With regards to the baseline medications that the patient received, Diuretics was the most frequently prescribed, followed by blockers of the renin-angiotensin system. However, we noted that a combination of renin-angiotensin system inhibitors, beta blockers, and mineralocorticoid antagonists was not frequently prescribed, and digoxin prescription was similar across the different heart failure classes. Regarding the etiologies of the heart failure, hypertension, cardiomyopathy was the most represented, and by dilated cardiomyopathy and peripartum cardiomyopathy, which was the least represented in our cohort. And we did a Kaplan-Meier adjusted curve, both for age and gender, and we found no significant difference in mortality after 36 months of follow-up across the different classes of heart failure. That is, we both reduce, regardless of whether it is reduced, mildly reduced, or preserve ejection fraction. And with regards to the different predictors of mortality, obviously we adjusted for other factors like age, the gender, and some cardiovascular risk factors like hypertension, diabetes, and echographic parameters. We found that relevant economic status indices like the education, patients who had no formal education had an increased risk of mortality, about 193%. Similarly, patients who had less than or equal to 3 minimum wage, and the minimum wage in Cameroon is considered 36,000. So patients who had less than 108,000 as monthly income had an increased risk of mortality. And also patients who were recruited as inpatients, that is patients who had signs of decompensation upon the time of recruitment, had an increased risk of dying too. And patients who had had heart failure for at least 2 years had an increased risk of mortality, and also chronic kidney disease patients had an increased risk of mortality. We also noted several important clinical aspects like the New York Heart Association functional class. 3 and 4 participants had a higher risk of mortality, and patients with signs of congestion, that is bilateral pulmonary arrest, also had increased risk of mortality. So in conclusion, about half of the patients in our cohort and certain poverty-related indices like no formal education and low monthly income were significant predictors of mortality. And also, we also know that relevant non-expensive clinical parameters like the New York Heart Association functional class and also aspects of clinical examination like pulmonary arrest were significant predictors of mortality. So heart failure is an expensive disease to treat. So in order to combat this, we recommend that strategies are employed to prevent the pool of patients who will develop heart failure. This can be done by treating most of the cardiovascular risk factors so that, as we saw, hypertension is the most common cause of heart failure. If we combat that, then we'll reduce the pool of heart failure patients in the country. And also, we can even go more further than, and we try to decrease the number of participants who get into the pool of cardiovascular risk factors. Thank you.
Merci, merci beaucoup. Alors, comme la présentation du professeur Nguyen n'était pas encore en place, nous allons en attendant prendre les questions.